Welcome to the Alfred Health Emergency Podcast, and we're back today to talk about COVED or COVID. And I have with me Associate Professor Jared O'Reilly and Dr. Rob Mitchell. Welcome, guys.
Yeah, hi Mike, and hi Rob.
Hi Mike. Hi Jared. Good to be back.
Yep.
And we're going to talk about the results of our first few weeks of the COVED Quality Improvement Project. And it's fair to say it's been some interesting times in Australia. The curve appears to be flattening, which we're very grateful for after looking at the experiences of other places in the world. And we're in a position where we have taken some data from our own organisation, and we are actually starting to get some other organisations on board with the COVID Quality Improvement Project. And given that the system is actually not seeing a huge amount of positive cases of COVID, which we're very grateful for, the question sort of lies around what the utility of this may be now and really where we're going with things. Rob, you've just come off a clinical shift today. And I suppose the question begs, what is the state of play of the COVID situation on the floor right now?
It's a good question, Mike. And I think, as you've already mentioned, we are in a vastly different position to what we suspected a month ago. I mean, I thought, I think we all thought that we'd be, talking about an overwhelming burden of COVID patients presenting to the EDs that we work out and captured in this, research and quality improvement project. But that's really not the case. I mean, Jared in a moment will probably talk about the data that's just been published from our first 2 weeks of the COVED registry. But in brief, among 240 cases who met testing criteria in our ED, there are only 11 positives. I think one of the things we can take away from this essentially descriptive exercise, first of all, is that despite the number of confirmed cases being relatively low, there are still a large number of patients who meet testing criteria or meet the criteria for a suspected case. So in our data set, in the 14-day study period, there were 1,508 presentations to our AED, and 240 of those, that's 16%, were tested. And as those listeners in Victoria, Australia will know, our testing criteria subsequently broadened, so that percentage has grown further, such that there is now a significant proportion of ED attendees who are being tested for COVID. And while we are in the incredibly fortunate position that we're seeing very few confirmed cases and very few sick patients with COVID, particularly those requiring respiratory support or admission to the ICU, the burden of suspected cases is significant, and I've experienced that in my shift today. One of the challenges is meeting the infection prevention and control requirements, which is a real battle, I think, as the testing criteria broadens. How do we meet the needs of these patients, but also protect staff members and importantly preserve flow through the hospital? I think this is, in one sense, it's a great problem to have, but it really requires constant attention and rapid turnaround of testing times so that you can remove isolation requirements as soon as patients, meet criteria or clearance criteria such that they don't need to be isolated anymore.
Yeah, I think it's a really interesting observation. It's something that certainly I've been privy to, having done some work with our ED leadership team over the last few weeks, that a lot of the work in the hospital is still around that burden of COVID testing and post-testing isolation is putting significant burdens on a system which is not overwhelmed at the moment, thankfully. But as things get back to some state of normality in terms of patient arrivals into the hospital, I can only assume that that those patients who we're, for all intents and purposes, treating as COVID positive for those first up to 24 plus hours in the hospital will continue to create ongoing burden and potential source for access block down the track. What are your thoughts, Jared?
Yeah, it's a big issue, and our results paper, this preliminary results paper, really put the focus on what a patient looks like that needs a COVID test rather than what a patient looks like when they're COVID positive from a test. So as Rob was saying, if you'd imagine, ordinarily our department might see 200 patients a day, but in recent weeks, and certainly in the first 2 weeks of April, according to these results, it was 100 patients a day. And out of those 100 patients a day, 16 per day were tested and isolated for COVID, and less than one a day were COVID positive at some point in their care. So that it's a very small proportion that were COVID positive, but we're treating everyone as being potentially COVID. So we're testing appropriately, as is everybody around the country, I'm sure. But it's a big volume of testing at the moment, really to ensure and protect our health services from undetected COVID positive patients being in the health service or being discharged to the community.
Now, I know you're a big fan of the Table 1, and I'm just looking through that myself. And is there anything else in the numbers that you can take out of this as potential early learnings?
I think the numbers were consistent with what one might expect with a study that's got some fairly clear criteria on who's being tested, which have moved a little bit, as we know, since the 14th of April. But for the first 2 weeks of April, most patients in this study sample had shortness of breath, or had cough, or had subjective fever. Few of them, in fact, had any overseas travel in the previous month or any contact with a confirmed case of the overall group of patients that were tested. There was a small number, again, of the overall number of patients tested that had fever or hypoxia or hypotension. These were the main findings of the overall group, and there are 11 patients, just 5% of patients, which is an important number but relatively small, that required mechanical ventilation in the ED, and a similar number, 12 or 5% of the overall population that were tested died whilst in hospital. If we then looked, and it's very difficult to make any inferences given how few COVID positive patients there were at 11, being 5% of those that were tested, but we can look at them and see that most of that group had actually had some overseas travel in the previous 28 days, not surprisingly, in the first 2 weeks of April, as a source of infection. Most of them they'd had contact with a confirmed case. Interestingly, and perhaps hypothesis generating, and perhaps not easy to measure, all of those who tested positive for COVID, being those 11 patients, had fatigue as one of their presenting complaints. None of them had fever, objectively, on examination. And so these were the things that were seen. But again, it's very difficult. We'd need more numbers over a period of time, and from more sites, ideally, to be able to make any inferential conclusions on what the COVID patient looks like compared to the non-COVID patient that's being tested for COVID-19.
Now, we've had a number of these patients come into us, I know, from other institutions such as residential aged care facilities, but also there's this cohort who have returned from overseas who've been furloughed, for want of a better word, in hotels and isolated in those places. Have you seen anything in the data that suggests that those patients may also represent an ongoing high risk?
Again, it's so I think that remains a possibility, and that's hypothetical at the moment. There's nothing in the data that's focused on those patients in particular. So for the first 2 weeks of April, we were looking particularly we were certainly asking a question as to whether people had been overseas. Less focused on the quarantine hotel aspect, which came to the fore more so perhaps in the second half of April, certainly in the Melbourne context. So we don't have any clear results on those patients and how they might have differed from the other COVID-tested patients.
And is it possible, do you think, based on the way that the data is being collected, that we are missing many patients, or that the forms that we're using for data collection could be actually not capturing all the information that we want, or are you pretty happy that that part is working well?
Look, I think that what is reassuring is that we're testing lots, as most services will be, I'm sure, and finding very few. So I think that's a very reassuring aspect, that of those who come into the emergency care system in Victoria and Australia-wide, that we're picking up on those who are COVID positive. We're spreading the net far, but staying within the guidelines. But they really are quite generous and broad for flu-like illness or respiratory infections that could be COVID, and also covering off patients who have no way of answering the questions that would exclude them from having COVID or make them not at risk. So some of those patients is being tested as well. It's possible, and we've seen even in the public domain, that that the tests may not be 100% sensitive or specific. So what may happen at times is there may be a positive test followed by a negative test, or vice versa. So we have to be cautious to conclude on the basis of one test. So keeping an eye on that data will be important going forward. But certainly who we're testing, I think, and who we're recording in our EMR, our electronic medical record, as having a test and why they had a test, I think that's quite complete.
That's good to hear. And have you had much interest from around the Australasian emergency medicine fraternity for this?
A lot of interest. And a lot of people, it's interesting, there was particularly a lot of momentum even a month ago everywhere. Two things happen when there's less cases. It makes people have more time to prepare, but it makes people prepare less perhaps, or prepare at a more steady fashion, which is appropriate, particularly for ethics committees and research governance. So it's good that nothing is being rushed at any point. There are at least several that are at the point of progressing the opportunity to join the COVID project. So that's pretty exciting, and hopefully we'll have some more news regarding that at the next COVID podcast.
Excellent. It strikes me, as you said, Jared, that we're moving into a new phase, I suppose, with COVID-19 in the Australasian region, and in terms of the next steps, it's complicated, I think. And I know, Rob, you've been doing some work with ASIM around particularly their education material and some of the communiques around that. What are your thoughts on where COVID is heading in Australasia from the emergency physician's perspective?
Yeah, I mean, I think we're probably in a holding pattern now to some extent, Mike, aren't we? I mean, there was a huge amount of activity, I think, over the previous 2 months to prepare EDs as much as possible, for a potential surge of patients with COVID-19. And as you mentioned, the college and many other organisations have done a lot of work to help EDs prepare for that. For those who aren't aware, the college has a lot of really good resources on their website, asim.org.au/COVID-19. And then includes some clinical guidelines focused on Australia, New Zealand EDs. There is some specific information about how you can zone the ED, how you can adopt triage processes, what is optimal treatment for COVID patients at the beginning of their care in the ED. So I think that's a helpful resource. But what's not captured in there is how you kind of maintain the momentum, which is what we really need to do now. I mean, no one knows how this is going to pan out. No one has a crystal ball. But the likelihood, I think, is that, this is the new normal, for many, many months ahead. And one of the risks is that I think we become complacent, that we potentially drop standards in PPE application and use. And that obviously carries, an increased risk of nosocomial transition. So I think we are all adjusting to the new normal. I think the flattening of the curve has given us the time to prepare. And I think we now wait for the decisions of, the public health leaders across the country and politicians, of course, about what's going to happen with restrictions. I mean, to a large extent, what we face in emergency departments and emergency care more broadly is very dependent on the public health response. And as restrictions are eased, which is inevitable, it's possible that there will be spikes and there will be surges and clusters, outbreaks, if you like, across the country. And so what may happen is that individual EDs need to respond to an increased number of patients. And that might carry on for many, many months until such time as, there is a vaccine, there is herd immunity, there is another a kind of public health response to deal with community transmission. So I think this is us for now, Mike. I think we've got to find ways of maintaining staff wellbeing. I think we've got to maintain ways of adjusting to this new normal. And I think we've got to find ways of not becoming complacent and making sure that we protect our patients and we protect each other as staff members.
Yeah, and I think that's very inspired information, Robert. It's definitely difficult times. I've found myself actually being in that state of readiness for such a period of time and having been head down doing so much preparation work that coming out the other side, it's interesting. It's an interesting feeling. And in some respects, looking at our colleagues and how they've managed in other places, it's we feel for them, I think, as a group, because we feel prepared, we feel ready, and some of that comes on the back of their terrible experiences, and knowing what to do in the next steps. I think someone in our organisation said, well, we're also breaking new ground by what we're doing, because these other countries that have gone through this have actually, they will come out in a different way than us. We'll come out, sure, with less positive patients and less burden in that acute phase in our system, but potentially with this chronic burden of patient presentations, and also this burden that I don't think we ever expected, which was the burden of testing, which is a very interesting burden, because within itself that has the capacity, if we're testing and isolating patients, to create major issues for our hospital systems, which I think were, at least for me, fairly unforeseen prior to this. What are your thoughts, Jared?
Yeah, absolutely. What a blessing. And Australia has to be thankful to those that told us to prepare and told us with great urgency to prepare for this situation. So we are moving into I'm not sure that it'll be a post-COVID phase, really. It'll be a chronic peri-COVID phase that we're never entirely clear. Certainly not clear we may be clear of this particular form of the virus, but things may change. So this is very much the new situation, and I think it will continue with some fluctuations. You can look at the curve in recent days, and it can look a little bit like the curve was about 6 weeks ago, just at the beginning before it peaked. And so there's always going to be that concern going forward, and so we have to organise ourselves, as we are doing, on how we manage the burden of testing, and have a situation that we're able to pick up when cases of a respiratory infection or otherwise are on the move, and through presentations to emergency departments is one way, certainly a very important way of picking that up. So again, we're very grateful, I think, to our colleagues who at the end of the northern winter were able to alert us that this was something to be reckoned with, and so everyone's taken notice, not just doctors. And so we're blessed to be in this situation to prepare. So it's a small burden to have to think about how to do that forever.
There's one other interesting challenge that I don't think we predicted, and that has been the drop-off of non-suspected or confirmed COVID presentations, such that, many of us, I think, are now worried that there are groups of patients out there, particularly vulnerable patients with chronic disease, who aren't presenting for emergency care. I'm a little bit fearful about how decisions to delay presentations for acute care will impact on health outcomes for those groups. I know there's lots of people having conversations around this, and I think it's a kind of another area of research that we need to progress to figure out who's not presenting, why are they not presenting, and what can we do as clinicians and in conjunction with our public health colleagues to encourage people who are in need of acute and emergent care to present to EDs. I suspect, I don't have data on this obviously, but I suspect that one of the reasons that individuals, the public, are concerned that by presenting to an ED, they increase their chance of exposure to COVID-19. And to some extent, that is true. But I think we all need to work hard to reassure our patients and those in the community that if you are in need of healthcare, that you should, present to an ED because we don't want people suffering at home, and we certainly don't want people dying in the community from preventable diseases that could be addressed through a visit to an ED.
Yeah, I agree, Rob. It's hard to fathom where the patients that we normally see go now and how they get their care, because I know that community-based care is also at lower than normal rates. So it's certainly a worry and possibly something that we won't actually have any data on for some time. And the only way around that, as you said, is those public health messages, which I know our hospital is putting out to request that people actually come into hospital if need be. And aside from that, it's a difficult thing to know and a difficult thing to manage, obviously. So interesting times, and the paper that Jared and Rob spoke about will be actually live in EMA, and so that will be out there for everyone to look at. Hopefully, we will actually continue this COVED project and continue to actually bring you information around that. And the design of this really is evolving, as was mentioned in our first podcast, such that we hope to flex to whatever the needs of the emergency medicine community around COVID are in terms of information sharing and data sharing. So look out for changes, minor changes in the data that we collect, and hopefully some of those will start to reflect that more chronic need that we are talking about as well around COVID management in Australasia. Thank you very much for your time, Jared, and thank you very much for your time, Rob.
Thank you, Mike, and I want to thank everybody that's been involved in the project, many, including the co-authors on the paper, people from very much the clinical and the research sphere in emergency department. And thanks for this opportunity today.
Thanks, Mike, and stay safe. That applies to you, Jared, and everyone else who's working in EDs. We, across Australia and across the world, in fact, we may have fewer COVID presentations than we expected. But as we've discussed today, there are still challenges out there, and we all need to take care of ourselves.
Thanks, guys. Until next time.
Cheers.